Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. Today we are in SOMSA 2022, and I am with Dr. DeMello. He's one of the professors for the master's program I'm with in CORAM. Thank you for being here.
Thank you, Dennis. Thank you for the kind invite, and I look forward to this podcast as I'm an excited person at the moment.
Oh, very good. Rarely do I ever get excited about anything. So, if you wouldn't mind, just do a little quick intro of yourself.
Sure. I served in the British military as a medical officer from 1976 to 2013. I was a commanding officer of battles for my last 6 years of service during the high tempo in Afghanistan. I've worked in burns for over 40 years, interest being following the Falklands conflict, and I'm currently chair of the pre-hospital special interest group of the British Burns Association.
So you're the perfect guy I need to talk to, because today we're going to talk about burns, right? And burns, it's just one of those injuries that just causes everybody to panic. It's just one of those injuries. It's up there with TBI, horrific injury, and it's instantly can throw just about anybody off their game. So when our approach to it, I think like anybody else, initially we talk about March, right? And all those injuries that you would find during March would kill the patient far faster than the burn itself will. Do you have anything, I guess, that we're missing in that initial kind of contact with the patient?
I think in the environment that you're working in, Dennis, the march it's important to keep a logical, sequential approach to the problem. Do not change it just because it's a burn, because a burn, as you said, is a distracting injury. A major burn, is a rare occurrence. Very few people have experience of major burns in their career. So it does catch you if you're not careful. So my approach would be follow the guidelines, MARCH, and just get on with it and regard burn as a issue to be considered, but not in the first review.
Yeah, absolutely. He's a trauma patient with a burn, not just a burn trauma patient, right? So tackle those problems first. Now, after that, right, we're pretty good at doing that March assessment initially. That's usually when the wheels, if they're going to fall off, they're going to start falling off pretty quick, because you have to get that initial assessment of that TBSA. And normally when we talk about it, we teach about it, it's pretty straightforward. You look at the burn, how big is it? But what guys don't really, I don't think, understand that well is this is a moving target, right? So if you could, I guess, how do I approach this pre-hospital?
I think you raise a very good point, because the calculation of the TBSA in a pre-hospital at its very best is going to be a guess. Immediately after the burn, it is very difficult to differentiate the areas which are just red, erythematous, or going to be a significant a burn wound. And a burn wound is like a geographical map. It's got contours. So you're going to have tissue that is dead, tissue that is static, and tissue that is just red hot. The whole purpose of your pre-hospital management is to reduce the zone of stasis, according to Jackson zones. And if you do that, there are two benefits. One is you reduce the TBSA that will then follow. Secondly, the depth of burn will be reduced. So your first response when you're assessing a burn in terms of TBSA, just remember that you will overestimate a burn by definition.
Okay. So I guess, so what, right? Because this is going to, ultimately, I need a number so I can start fluids. I know I need fluids. So what if I'm too far off?
Okay, so let's look at the fact that you're going to have to calculate the TBSA, whichever method you're comfortable, whether it's the 1% palm and fingers, or whether it's the rules of 9, a Lund-Browder chart, or serial halving, which is something that is becoming easier to do because it doesn't really involve any numbers. You just look at a patient, eyeball them, and you work in fractions. So is it more than 50%, less than 50%, more than 50%? So is it more than 75, less than 75? And comparative studies of these ways of measuring TBSA have shown serial halving to be the best. And can I just make one point, which may not be possible in your environment? For God's sake, don't forget the back.
Yep, absolutely. And that's definitely something that does happen frequently. So the serial halving, to be honest, I haven't heard about it until you just said it. So greater than 50%, less than, greater than 75, less than, I guess, how does that affect the fluids that I give?
Right. Now, let's differentiate a major burn versus a major burn with major trauma. So I'm now talking just of a major burn on its own. So that should be picked up from the mechanism of injury. So some guidelines. If you know the mechanism of injury, if the patient's been thrown in a blast or there is obvious evidence of trauma, you stick to your march and just get on with it. And a burn will now be just a significant contribution to the pathophysiology. I'm now talking about a pure major burn. Rules. If a patient's hypotensive immediately after a burn, there is something else going on, another source of blood loss, chest, abdomen, pelvis, long bones, full stop. The second is that if you've got a major burn, showing you the difficulties in assessing TBSA immediately after a burn, and the worries of using any formula for your calculation of fluid resuscitation, there's going to be a double jeopardy. You've messed up the calculation, and now you're transfusing crystalloid or under transfusing. So you've got a balance to make. Do you protect the kidney if you're under resuscitating, or do you mess up the lung if you overdo it? But in your situation, in the pre-hospital environment, it doesn't really matter. And certainly experience over the years, TBSA calculations in the middle of a care under fire is going to be difficult. So let's assume they've got bilateral radial pulses. My view on fluid resuscitation is in your team, the chances are they're going to be a big man with a big burn. Just put a liter of fluid up and run it over an hour whilst you get on with the other processes. And this was published in 2007 in the Journal of the Royal Army Medical Corps, and it's just taken away the hassle of working about formulae. So now you're going to say, well, how good is it? Well, when you eventually start looking at urine production, that will give you some surrogate evidence that you're doing well, plus evidence that there may be another problem that it can interfere with urine production.
Okay. And then, so I guess you're running that fluid until you essentially you're getting your urine output.
Or you've got a time now to go back to the formula and start looking back and reviewing the situation, by which time hopefully your TBSA will be more clear. The vital signs, you will have a video of the trends in your vital signs, which includes urine output.
Okay. Yeah, perfect.
There is just one thing, Dennis, that I just want to interject. We always have a tendency in emergencies never to give people oral fluids. If there is no upper airway burn or evidence of inhalational burn, I think it's only humane and also evidence-based to allow a patient to have clear fluids. And what I mean by clear fluids is water. And in that way, you're also feeding the gut.
Yeah, absolutely. So you're not just talking straight water, you're thinking ORS or some kind of hydration drink. Okay. To what level, or I guess what burn, assuming it doesn't have to do with the airway, can you start resuscitating? Because usually these patients, if they have a bad burn, I want to snow them as quickly as I possibly can because their discomfort is throwing me off. So, obviously, in order to get them to drink, they have to be able to be awake and swallow, right? So, what level of TBSA are you doing this?
Okay, let's go into the pathophysiology before I answer the pragmatic approach. In an average adult, a 20% burn will have a systemic impact on the pathophysiology. So it's no longer the burn wound, but it's the whole body reaction. So that's your cutoff point. Fortunately, hopefully, the majority of your patients will be ASA1 status, and therefore their ability to counteract a shock to the vital signs will be better coped with. But I would say anything above a 20% burn would require resuscitation and would require more care, for want of a better word, in terms of prolonged field care.
Oh yeah, absolutely. But I mean, are they doing oral rehydration for patients who have 40%, 50%?
I think it depends on the neurological status of the patient and the absence of any upper airway burn or inhalational burn. I think it's humane if a patient asks for water, give it to them. Start off with small sips before. I'm not talking about large volumes. That's the first thing, and the second is setting these patients up if there's no contraindication, because if you set them up, they're able to swallow. But more importantly, if they've got an upper airway burn or as the burn wound swells, gravity will push the fluid to the lower regions and therefore reduce swelling of the upper torso. And with work done by Fiona Reid dealing with the Bali bombing, she found that if she sat these patients up, it just massively reduced the need for intubation or surgical cryo.
Yeah, and that makes perfect sense. Just basic orthopedic injuries, rice, right? Same swelling that happens with twisted ankles, the same one that's going to happen with the burn. But speaking of that, how fast should I expect this burn to swell? Because they always talk about the initial, right? Put the guy out, march, and then they talk about the guy who's now in an ICU and he's swollen up like the Michelin Man, right? But how long between the guy on the X to the guy in the ICU is he supposed to?
So let's target the upper airway or the upper burn, because that's what's relevant in terms of the airway protection. After a major burn involving the upper torso, you're likely to get your swelling maximal to be problematic between 18 to 36 hours post-burn. So you've got that window of opportunity. Now, I'm not saying that you may not have to do a surgical cryo before a helicopter transfer. But in the immediate 4 to 6 hours of that, if you can set them up, that would be a very low priority for me, unless there is evidence from the history, from the mechanism of injury, that there is a inhalational burn.
Right. So you're talking about blast or enclosed fire, things like that. And then, of course, somebody has a long transport. I think guys think of crikes as like a permanent thing. Like from now on, he's going to walk around with a stoma. They can be taken out just as easily as being extubated as well. So, if you think that the patient may need it, and you don't want somebody to have to do this in the back of a helicopter or back of a fixed wing, then it's probably better just to do it prophylactically there on the ground.
I agree, Dennis. I think we have to be honest when we're facing our patient before transferring them up to another level of care or to another team. I don't think you can pass the buck to somebody else. So I agree with you that if you think that the surgical airway is likely to be useful, to be crucial, either from your assessment or as a result of the transfer logistics, I agree that you should go ahead and do it. Now, every intervention you do has a downside. So let's forget about the downside, because that's obvious to the people we're talking to today. But the important thing is the nice thing about a surgical area with a trachea tube. If the patient's awake, if the patient's neurological status dictates it, and he is determined to get it out, you've got permission to do so, and you can clear up the secretions prior to extubation. Extubation in a maximum inspiration, so that they can cough up whatever's collected above the cuff and any secretions that may have accumulated. And just apply a dry dressing over the wound. Do not intervene or suture or staple the wound. Let Mother Nature heal her. And more importantly, if the patient does deteriorate in mid-flight, then you've already got a stoma. So I believe in just keeping your options open. So cover it with a sterile dry dressing.
Yep. Perfect. Very good. What else? Airway. There was something else we wanted to talk about with airway, other than, I guess, just elevation.
There is another clinical pearl I would like to introduce. You know those gray areas where the patient's had an inhalation burn? There's a bit of stridor, but not as much. The work of breathing is okay. And let's assume this is a otherwise fit patient. A milligram of epinephrine nebulized in 10 mils will give you shrinkage of the upper respiratory mucosa and buy you time. That's another useful trick.
Yeah, absolutely. No, that's definitely a good tip. And then combine that with his, sitting up, definitely, hopefully avoid having to take his airway to begin with, right? And obviously that principle also applies to elevating limbs as well.
Yes. Okay,
perfect. So hopefully avoiding those eschorotomies and compartment syndromes and things like that. So we talked about TBSA, and then if you needed to take the patient's airway, what about fluids? So we understand crystalloids, large volumes of crystalloids, but unfortunately we do not have cases of lactated ringer and then next to it cases of normal saline. We have a mix of both. In our training, we're always kind of taught like normal saline will kill everybody that it touches, and lactated ringer is the only thing. What are your thoughts on that?
Well, I'm old enough, Daniel, to see fashions come and go. When I grew up, when I was starting anesthesia training, normal saline was the crystalloid in the non-US environments, and it's only when the large volumes of normal saline were used and you got your hyperchloremic acidosis, which is why it's relatively gone out of favor, and now ringer lactate or Hartmann's is the crystalloid of choice. But let's be pragmatic. If you've got no other fluid, you just go for anything that is isotonic with plasma and just get on with it.
Yep. The fluid of choice is the one you have. And speaking of the one you have, is you probably have a unit of blood around. You have a patient you've been sitting on, we're skimping on fluids. Maybe we haven't tried oral hydration or rectal hydration yet. That blood bag starts to look pretty tempting. Is there what's the good and what's the bad about giving that?
Right. I think in your environment, resources like blood are critical. So let's look at a critical care situation. If your normal HB is between 14 to 16, you have a bleed out. There is a level at which blood flow through a capillary becomes easier as your hematocrit drops. So what you're talking about or what we talk about in terms of resuscitation, we talk about the macrocirculation, using vital signs like blood pressure, heart rate, urine output. I'm really interested in what is best for the microcirculation, because that's where the oxygen is delivered and where carbon dioxide is taken out. And the good news to report is that an HB of 10 or hematocrit of 30 is the ideal cutoff or trade-off between the microcirculation and the macrocirculation. So I would not use blood, assuming you were starting off with a normal baseline, and in the kind of scenario you were talking about, my blood is too precious to give this guy.
Okay. So just to push the question even further, I was like, this is what I got. I really want to send it, and so I do. What is the potential complications going forward?
Besides the use of a huge acid, the second is you might run into hemoconcentration. And with hemoconcentration, you're going to get sludging, and if the patient's been thrown or there's been some tissue damage, you've now got the triad of for clots, and now you're going to, down the line, you're more like, and because the patient's got to be immobilized, God knows for how long on a transfer, you've got a deep vein thrombosis risks going up, and now you've traded one problem for a future problem which will kill him.
Right. So you get short-term satisfaction, but long-term
risks are not worth it.
Yeah, absolutely. Obviously, would the same apply to like FDP or any kind of plasma?
Yes, I think all blood products, and I would also like to include human albumin solutions, because human albumin solutions was very trendy a few years ago. And it was felt that if you gave a human albumin solution, concentrated human albumin, like 20%, it would suck in fluid from the extravascular space and maintain intravascular status. Unfortunately, it's transient, and we're treating ourselves rather than treating the patient. And there is no doubt that in a major burn, which is going to become catabolic over time, the impact of a transfusion of human albumin solution is transient, a waste of time, and a risk of putting stuff into the circulation.
Right. You know, if I remember correctly, so even if you did, you're ultimately going to get a lot more swelling, because as that protein goes through the capillary cell wall there, now you put a bunch of proteins in the tissue, which is now going to draw your fluid out faster.
Yeah, and I think that is my point. Once, do you remember I said to you, above 20% TBSA, you're going to get a general systemic inflammatory response. So now you've got capillary leakage, and now you're putting a macro solution of 70,000 perhaps molecular weight. That's going to leak through. That's going to absorb fluid. You're just going to make the trajectory of this patient worse, because the tissues are going to be even more edematous than they would have been if you had just taken a second or two to work out not just the short-term thought-of benefits, but what impact is it going to be on the trajectory for that illness pattern. And I would say, don't bother.
Yep, absolutely. Let's talk about pain control. So I guess how are you approaching pain control with the burn patient?
Just to make some general observations. Burn is a distracting injury. If you've not seen much of it, it can be horrifying. You forget your logic. You just rush in because the pain is unbelievable. And the reason for that is that it is acute neuropathic pain. So these are my feelings about the approach to analgesia. First of all, make sure you got your March assessment in first, so that you don't overdo it. The second, from years of experience from Afghanistan, Iraq, we know that if you use morphine, you are more likely to drop somebody's blood pressure and vital signs. So this is why the move is now towards a fentanyl-like, if you were choosing an opioid, because it has less chance of doing that. So that's the first point. The second point is an acute burn is actually an acute neuropathic pain. So the best analgesia on paper must be an NMDA antagonist, which is ketamine. Now, I don't really care which route you guys use. It doesn't really matter. But for me, the quicker you use it, the better, because you're relying on peripheral and central sensitization to make it a chronic problem in the past. So if you can use ketamine in analgesic doses, And for the less experienced, I would say 10 to 20 milligram IV boluses. Aspect is some people who believe they have to give a benzodiazepine to reduce the psychomimetic effects of ketamine. I think if you know your patient and if you tell them that you're giving them ketamine, or if you can have warn them in training that the psychomimetic effects of ketamine are real, but if you can walk through it, don't worry. So I very rarely gave midazolam in addition to ketamine boluses as I grew older, because I was confident that I could convince the patient that seeing pink elephants and yellow giraffes was normal given the activity of the drug, and therefore you're also reducing the fear and also minimizing your polypharmacy. Now, the one slight caveat: midazolam is very good for retrograde amnesia. So I think if somebody's badly burnt and their status is okay, 0.5 to 1 milligram of ketamine is going to make a difference on its impact on PTSD and recall.
With Versed, you mean? I mean midazolam? Yeah. Okay. Yeah. I think guys just have to keep things in priority. They try and cram too many things in all at once, and then they end up getting in trouble because the Versed, the midazolam, I believe is probably the most dangerous drug you're carrying.
Correct. And that's why I said if the status is stable, if the patient's trend analysis is stable, this can be done later. It's not an immediate intervention, but it's something I think when you're looking at the psychological and mental health aspects, those are the rare times when I would use midazolam. But to be quite honest, in doses of less than 1 milligram.
Okay. Yeah, and just start slow, like you mentioned before. With ketamine. 10 milligrams, 20 milligrams, small bumps, walk them to an actual goal, not just, I want them to stop screaming at me. That's not a real goal. You're talking like a pain scale, some kind of description of the patient. Like, I want him to be able to look at me and talk to me, but not be screaming in pain. Some kind of goal that you can actually titrate to. Because I think we use titrate to effect way too much, and we use it as like a blanket for, I know what I'm talking about because I said I'm going to titrate to an effect when they actually have no idea what effect they're looking for.
I think you raised another good point, Dennis. Depending on your patient, I think explaining what you're doing is important. I think if you're going to try and achieve a pain-free patient, you're wasting your time. I think a reduction of more than 3 points on a 0 to 10 scale is regarded as a good target to go for. Aiming to be pain-free, I think, is dangerous because you can tip over the edge and then run into problems now of overdosing and losing control of the airway or mental status. Once it's in, you can't take it out.
Right. Yep. And especially with Versed, that can be a long ride. Ketamine, you kind of brush that one off, but some of the bigger drugs, like, you're going to take that for a ride. So that's, and you're talking more analgesia versus a procedural sedation. So let's talk about escharotomies. Okay. So obviously this is a procedure. How do I go about preparing for this procedure?
The timing of an escharotomy is really critical, and I'm aware that you're talking about a range from a few minutes to a few hours to 5 days of prolonged field care. So I'm just going to try and give you an overview escharotomy. Sure. Just because you got a knife, it doesn't mean you have to do an escharotomy. Secondly, an escharotomy is dead tissue, but the edges of the escharotomy are exquisitely painful. So if you're planning to do an escharotomy, what are the reasons? The reasons are, certainly in the early phase, is that it's embarrassing ventilation or embarrassing urine production by providing a secondary abdominal compartment syndrome. So those are the two critical areas. The chest in terms of ventilation, the abdomen in terms of urine production, and therefore guiding your fluid resuscitation. I'm not talking about the escharotomies that you would have to do for the lower limbs, because those are separate issues. Now, when you're doing an escharotomy, I'm assuming you don't have blood products. And I'm assuming that the whole staging of an escharotomy, what you want to do is the time you take the knife to the eschar, to the time you've packed and the wound is covered, must be minimized. And so I would say that your anesthesia or analgesia or sedation protocols are one side. The logistics as to who's going to do it and what help you're going to have is on the second side. And on the third side is what are you going to put on the wound. All of those should be ready before you do an escharotomy. And just like an aircraft journey, your pre-flight checks, one would be, we know it's going to be bloody. We know it's going to be painful. And therefore, the analgesia of choice for me would be ketamine for the reasons I've given you. The other is, how do you minimize the bleeding? You can bleed your whole blood volume if you're not careful. So how do you minimize that? And so I would say a bag of crystalloid with a milligram of epinephrine pre-infiltration before the incision would be one way of minimizing the blood loss. The time of doing the escharotomy to the time you pack and apply pressure must be telescoped down to the shortest time, because compression is the best way around reducing blood loss. So the answer to your question is, if you have to do an escharotomy, think through the process, telescope it down in time, pre-plan your positioning of your bandaging or wound cover, and keep the time to a minimum.
Yeah, absolutely. I think when you prep for an escharotomy, they think about the procedure itself. They rarely think about the before and after. So, timing of when that push goes in to get the max effect out of your ketamine, right? They push it, they wait 10 minutes while they get the rest of their gear, and then by the time they're ready, the patient's starting to come light again, and now you get to do it again. What kind of dressings are we going to do? All these extra steps, and then consequences, like maybe we need to do blood, if we don't have blood, well, what other fluids do we have? And kind of think about all these, the good and the bad of all these procedures. And then ultimately, like, what's my end goal, right? What are you assessing for? What should be returning, right? Guys need to think about this before you even really start. So that's the thoracic and abdominal. Is there any other extra points as far as extremity type escharotomies?
The procedures in terms of the incisions are important, and the lines of Langerhans, which are cosmetically the lines that you should be following. You can find it in any illustration, because from a cosmesis point of view, so I'm talking about the long-term point of view, where you put your incisions are important. So before you deploy, just have a look at the lines of Langerhans and follow those rules. The extremities are easier to control because blood loss is easier to minimize by elevation, by pressure, etc. The only thing I would worry about slightly is the escharotomy and also the possibility of compartment syndrome. And so, for example, high voltage electricity, you would think of compartment syndrome and also escharotomy, because it can literally blow off all the tissues at the point of entry. And that heat process, we've not said anything about the cooling the burn, but if it is physically possible, cool the burn. And that ability to cool can go up to 3 hours after a burn. And the reason for that is that if you cool a burn, you minimize the TBSA and also the depth of burn.
Right. So actually, if you don't mind, let's talk about that for a minute, because, we have hypothermia management beaten into our heads day in and day out. Everything is about maintaining heat. And, even in burn patients, we always talk about hypothermia management as well, right? Because they get very cold. They have this big wound. Heat pours out, fluid pours out. But what you're talking about is in that initial stage, correct? Cooling the patient and trying to remove as much heat out of that injury or extra heat, right? So I guess, how do I accomplish that?
Well, that's the logistic limitations that you guys have got to face. Let's just for simplicity first talk about a situation, a burn in a non-operational critical situation. Cooling the burn is exponential. The a major burn cooling, where they become fish-like poikilothermic, so they take the temperature of the environment, which brings the whole issue about a patient being kept warm. In the first 2 hours of the burn, that is not your priority. Your priority is to cool the burn, but not the patient. So any way in which you can cool the burn but not the patient is the most important thing, and that the benefits of that can go up to 3 hours post burn. Be careful of the melted clothing like belts, jewelry, or all restrictive tourniquet like restrictions that might occur as the burn gets older and edema ensues. So cooling is important, but cooling the wound. But I'm not saying cool the patient. So let's go back to your point when you talked about escharotomy and about exposure. In the part of the preparation for the escharotomy, you should be covering the parts that are not going to be exposed to the elements. So that should be part of your process. How do I mitigate heat loss and keeping the patient comfortable? So that is heat loss mitigation is just as important. But in terms of cooling, if you can, logistically, do it up to 3 hours post-burn.
Okay. And so obviously we're managing this, we're monitoring and trending this stuff as far as the patient's temperature. Are you taking them to 37, 38 degrees Celsius or 98.6 degrees Fahrenheit? Are you taking them straight back to normal, or are you starting...
I would say normothermia is the safest, so whatever. So if the patient feels comfortable, if the peripheries are warm to touch, I'm talking about the first few hours of the burn, because I don't want people listening to this podcast forget the chance of sepsis in a prolonged field care situation. So I'm clear in my mind that what I'm talking about in the first few hours of a burn. Yes, don't throw somebody into a bath of cold water, but I'm just saying cool the burn as quickly as possible, and you get more bucks for your money if you do it in the first 20 minutes than in your first 3 hours.
Okay, so you're just talking about wet cloths?
Yes, wet cloths, but if it's wet cloths, change those cloths regularly.
Okay, perfect. So we were talking about earlier with abdominal compartment syndromes and fasciotomies and issues with urine output. How can I really tell rhabdo from just dehydration? Because both of them can be pretty dark.
I think it's a very good point, Dennis, because urine color is critical in your trend analysis. So let's look at some practical issues. Everybody knows that if they're dehydrated, their urine is going to be dark, and if they've been drinking a lot of water, it's going to be light. So we all know that. The problem is that in a major burn or in a major trauma like a crush injury, you've got two possibilities. You've got myoglobinuria and rhabdomyoglobinuria and hematuria. If you've got microscopy, if you've got red cells in the urine, that's hematuria, but it's a guess. The difference between rhabdo and myo really not important in the early phase, because your reaction is going to be the same. You're just going to promote a diuresis. So you're just going to increase the fluid resuscitation volumes to flush out the kidneys. I find serial bottles of urine taken over a period of time and marked, and you can see the color changes. I have to see the trend before I can make sure. So that's another useful tip. When you put a catheter into the patient, urinary catheter, keep a sample, time it, and then maybe 3 hours later, if it's getting darker, time it, and so you get a chance to sort of look at the trends in color. And if you're doing telemedicine, somebody can have a look at that. And it's obvious. So it's not just urine volume, it's the quality of urine that I'm more anxious about. So if you think the mechanism of injury suggests just a pure burn, that's likely to be a myoglobin urea rather than a hematuria. So those would be my guidelines.
Perfect. So in your experience with pre-hospital and teaching medics and observing medics, what things with burns do we screw up routinely?
I think the most important ones are the overcalculation of TBSA, and therefore a double jeopardy of over fluid resuscitation. I think that's important. Not looking at the whole body, looking for other coexisting possibilities of trauma. And from a patient rehab point of view, is the failure to provide tender, loving care. Because when I talk to my military patients who have been through rehab and they come to me in the pain clinic, I ask them to tell me their story. And they can tell you in graphic detail the conversation between the paramedic and another paramedic, or the lack of talking to the patient, the lack of reassurance. So those things are also analgesic.
Yes, absolutely.
Reducing anxiety can reduce your pain requirements by tenfold. So for me, those are the kind of things that I would like my medics to have a little bit of compassion, because you can't overdose anyone with the compassion, but you can certainly with any of the drugs we use in clinical practice.
Absolutely. Well, thank you, Dr. DeMello. I really appreciate it.
Thank you, Dennis, and look forward to listening to the end result.
Absolutely.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.